inaugural MedEClasses postgraduate lecture series. As we discussed earlier, that pediatric endocrinology is one branch of pediatrics which is very fascinating. It has got a lot of challenges. And unfortunately, the exposure is limited in pediatric endocrinology with regards to especially the postgraduate teaching. And that's why we've taken this initiative. I am really honored to have Dr. Sonal Shah from MP Shah Medical College, Jamnagar, who has joined us as the expert faculty for this program, and Dr. Sayan Banerjee and Dr. Prateek, who are from Regency Center for Diabetes, Endocrinology and Research, who are part of this program. So the way we are planning is that over the next 36 months or so, we will have a session every month on one of the Saturdays, preferably the third Saturday, in which we're going to cover the different aspects of pediatric endocrinology relevant from pediatricians and postgraduate perspective. This will have a didactic lecture. At the end of the lecture, we'll also have a discussion about practical points as well as how to respond in terms of exams and these stations as well. So I'd like to invite Dr. Sonal as an expert here and share her comments. Dr. Sonal, please.
Yeah. Good evening, sir. Thank you for giving me the opportunity for the postgraduate webinar series. It has been a great pleasure to be here with a legend like Dr. Anurag sir. He's a master in endocrinology. I have done a basic course under him, and after doing the basic course, I have been able to implement so many new things in my department, and postgraduates have benefited a lot because of that. And I hope with this webinar series also, the postgraduate will learn more and more, and there will be more awareness about the endocrinology. Thank you.
Thank you, Dr. Sonal. So this program will also be available on our website in a recorded fashion as well as on YouTube. So this are all complimentary. We'll start off the program right away. So I hope the screen is now visible, and we'll start the session right away. Okay, so as discussed today, we're going to start off with the growth module, and the next 5 talks are actually on growth. We'll talk a bit about how to really measure and assess children. Then we have a session on growth chart and bone age. We'll have a second session on short stature subsequently, and then there will be an interaction between Dr. Sonal, Dr. Prateek, and Dr. Sayan about these aspects in that regards. If you have any queries or questions, you can put on the Q&A chat, and we'll address it towards the end of the session in that regards. Now, all of you can go and have a look at our website, learning.growthsociety.in, which has got multiple options available with regards to resources, which are free resources, as well as different modules. A lot of resources are available on YouTube. There are over 300 videos which are available, which are there for access, and we'll be posting this recording as well there. And you can go in terms of assess our courses, which are there ranging from fellowship to postgraduate courses as well. There are 3 specific free webinars which we conduct every month. One is related to advanced pediatric endocrinology, which happens on the 4th Saturday in the afternoon. Then we have one for the basic pediatric, which is done basically for postgraduates and pediatricians, in which we have case discussions. Today we had a very interesting case of DK there. And the third one is this, which we are starting today, which is a monthly lecture series starting for growth in that regards. There are publications which can be accessed through our website, as well as mobile application, which really makes it very easy to implement. And we'll showcase a few things with regards to growth chart and bone age today in that perspective. So this is how we plan it over the next 3 years or so. We'll start with growth assessment, followed by short stature, growth hormone therapy, obesity, and there'll be one session in which there'll be case presentations, which will be done in that regard. So this is how we plan to go ahead.
So we will be basically discussing what basic questions might come for the postgraduates in their exams, what points to cover. And for that, we have Dr. Sonal Shah madam from SPMS Jamnagar, and she will give her valuable inputs regarding what all should be covered and which will fetch the maximum marks. So madam, beginning with the first question, that is define growth, development, velocity of growth, median, mean, percentile. So what should we cover in this question?
Yeah. So basically it is, we have to write the definition of the growth. So growth is nothing but the increase in the cell number and the size. And the development is the maturity of the functions of the cells. Okay. So this is clearly you have to define between differentiate between growth and development. The second one is mean, as Anurag sir has already very well explained that mean is the average of the, you multiply all the observation and divide by the number of the observation, and that comes the mean. Median is if you put the observation in an ascending order, and the 50th reading is your median read. And the percentile is nothing but if you arrange the numbers in ascending order. Suppose if you say that 80 percentile means you are at the 80th rank and only 20 people are taller than you, particularly if you consider the height. So by giving examples, you have to write and you have to clearly differentiate between mean, median, and percentile. Okay.
So I think these are the various points which should be covered, as Madam mentioned. There is a definition of growth, definition of development. I think Sir had also mentioned the ICP model, the various different velocities of growth.
Yeah.
Both monitoring yes.
Yeah.
Yes.
So I would like to highlight on that ICP model is nothing but infant, childhood, and puberty model for the growth. So that indicates that we have, because we are dealing with a child from the preterm baby to adolescent child, it's a continuous process. Growth is a continuous process, and that's why we need, and the velocity of the growth is different at different ages. Okay, so maximum velocity of the growth is in the fetal life. That is, fetus increases by 50 centimeter, and then the next period after the fetal life is the infantile age group, where the maximum velocity, so usually it increases by around 25 centimeter, and after that the maximum period of growth is in puberty. Okay, and after 2 years of age, as Dr. Pratik has already mentioned, if you can't remember, if growth velocity, so because velocity has to be taken every year, and if it is less than 4 centimeter, it should be investigated. So after 2 years at any age till puberty, if growth velocity is less than 4 centimeter, it should be investigated. So that has to be highlighted, and they should know about the growth velocity curve. Also, they should know how to plot on the growth velocity curve, and less than 25th percentile is considered as abnormal growth, and less than 10th percentile on the growth velocity curve needs investigation. So this has to be highlighted. Okay.
Thank you, Madam. And so, as mentioned, growth chart plotting has been extensively discussed, as well as the various measures of variation.
Yeah.
Coming to the next.
Yeah, and one thing I would like to highlight that growth monitoring, because monitoring has to be done, and as highlighted by Dr. Pratik, it has to start in the newborn period, and phallic length has to be taken of each and every newborn, so that we don't miss the conditions like hypopituitarism or CH or something like that. And at BMI after 3 years of age, it should be taken in each and every child. So that I want to highlight that.
This was also mentioned, what is the difference between percentile and SDS, and this has been extensively discussed.
Yeah.
Main various drawbacks of SDS and percentile are there, and we should keep that in mind. Yes, ma'am.
Yeah, so like basically we have to find out percentile. You have to understand that percentile indicates the rank, your rank in the particular observation of reading, while SDS, how much it indicates the severity. So you have to, SDS, if you want to know the follow-up of that particular child, particularly if you put the patient on growth hormone therapy, and if you want to assess from -5 standard, -3 standard deviation, now patient has come to the -1 standard deviation. So that severity and follow-up is more useful when you use the standard deviation score. Okay.
So coming to the next question, basically, what is the basis of use of growth charts? What is the evolution and the various characteristics of growth charts, and what are the implications? And now they're focused on malnutrition, but we can focus on other aspects as well. So, Madam, proceed from this question.
Yeah. So basically, like most important is to monitor the growth of the child. For each and every child who comes to our OPD, whether indoor patient or outdoor patient should be plotted on the growth chart with the defined anthropometric measurement criteria. And we should use the standard growth charts. As Anurag sir has already mentioned, we should use the recent one, country-specific growth chart, and we have very specific growth chart, IAP growth chart, which is available. It is a reference growth chart. So you should know the difference between reference growth chart and the standard growth chart. Standard growth chart, usually it's a longitudinal, multiple readings are taken, and it is taken in the ideal circumstances, and that is WHO growth chart, which we use it for 0 to 5-year-old child. And the reference chart, they are used basically, they are cross-sectional, and this is IAP growth chart, what we use for 0 to 18 years of age. They are the standard growth chart. They are the reference growth chart, so that you should know the difference. There are CDC growth charts are also available. There are many other growth charts are also available. But for us, we have to use the IAP growth charts, which are meant for 0 to 18 years of age. We have to use the gender-specific growth chart. For boys, it is blue color. For girls, it is pink in color. And we should not forget the weight for the height chart for 0 to 2 years of children. And we should use also the IAP growth chart for BMI. So for each and every child after 3 years of age, we should also take the BMI and plot them on the chart. And we have another disease-specific charts are also available for Down syndrome, Turner syndrome, achondroplasia. If that disease is there, that we can use that particular chart. And we have also IOTF chart, that is International Obesity Task Force chart, but there the measurement reference values are different. So we should use our country-specific charts. So that is the message.
Exactly what Mara had just so exhaustively explained. There is a difference between reference and standard charts. And this also has been explained, madam, I think.
Yeah. So this is, I think, Anurag sir has already very well explained that this is for the 0 to 5-year-old WHO standard growth charts are there, where standard conditions are like there is a single tone fetus, normal birth weight, exclusively breastfed child, no maternal smoking, and no other major problems, and how the child should grow ideally. So that chart mentions that, but reference charts are different. Okay.
So now, as explained, the various evolution, I feel the various evolution of the growth charts and what was there before, what has come, such as national charts, the Agarwal charts, Khandekar charts, disease specific such as Down, Turner, Noonan's chart, growth velocity chart. So many charts are available, and we should make use of this. And as madam has very well explained, color coding, and one important point is the labeling at the date of birth is very important to mention, because it is mentioned every time. Just check it.
So date of birth exactly, and you have to write the age in months exactly. 2 years, 3 months, 2 years, 4 months, and exactly put the dot. Don't put arrow or any other thing. Put a dot, and then find out the mid-parental height. Okay. So sir has already, Dr. Pratik has already explained about how to take the mid-parental height. Most of you also know it very well. But whenever the patient, you plot the reading, you have to take the mid-parental height and make a habit of putting the mid-parental height on the chart, and make the +6 and the -6, and decide about the family range, particularly range in which the child can grow. Okay, so taking the mid-parental height and taking the range +6 and -6 is very important.
And exactly.
And then find out the heightage and the weightage, as very well explained by the sir. So these are the certain steps. First, you write down the date of birth, sex-specific chart, put the arrow, find out the MPH, then find out the heightage, then find out the weightage, write the chronological age, and depending on that, you can diagnose, just from the growth chart, you can diagnose many illnesses. Okay.
Now coming to the final question, that is the bone age assessment. and enumerate the various methods, and how does bone age help in diagnosis of various short
Yeah.
stature?
Okay. So this is a common question which is asked in the PG exams. I know it is very difficult to remember the how, but you can, I will like to highlight that bone age is required to be done in whenever you are dealing with a patient of short stature, delayed puberty, or a precocious puberty. So it is a very useful tool. It is not that difficult, but and it is to be done for all ages. We have to take the X-ray of the hand, non-dominant hand, finger should be fully sprayed, and there has to be adequate exposure. And what are the areas? What we need to see is carpal bones, which are not very useful, but they are useful in the infancy. For neonates, it is useful. You have to see the lower end of the femur. If it is absent, then it is in neonatal period, lower end of femur ossification center is absent. Then you can say that the child is having a delayed bone age, maybe suffering from hypothyroidism. Another area we have to see for the infancy, you have to see the carpal bones. And then next, after 2 years of age, you have to see the epiphyseal center of the distal phalanxes. Phalanx you have to see, and then you have to compare the size of the epiphysis and the metaphysis. If epiphysis is smaller than the metaphysis, usually the bone age is less than 7 years in case of girls, and the boys it is less than 9 years of age. Then after that age, epiphysis and the metaphysis becomes equal, and then after 12-13 years of age, the epiphysis become wider than and capping occurs, and then the fusion occurs. And the another area to be seen is the distal end of the radius and the ulna. Usually the distal end of the radius usually appears, epiphyseal center appears early, but ulna in girls, it is around 5 years, and in boys, it is around 6 years of age. So we have to see the carpal bones, phalangeal epiphysis, their size, their fusion, and you have to see about the distal end of the radius, ulna, and their fusion. Okay. And then, and there are different methods also. This is the rough, quick method by which you can assess the bone age. And you have to generally believe that usually the female are advanced by 1 or 2 years than the boys in the bone age. And usually, and there are various other methods are also there that you have to mention. One is GP-Atlas method, which is little cumbersome, and the inter-observer variation will be there. Another one is Tanner-White method, TW3 method, and there it is exhaustive method. Inter-observer variation is less, but it is little cumbersome method. So best is to use Bone Expert, but it is not easily available. But as I told you, and as Anurag sir has well mentioned, you have to see these 3-4 areas, and roughly you can decide about the bone age.
I think one very important factor, at least practically speaking, is we get many X-rays which are cut in the middle, which are half, and we should tell them to how to which X-ray should be taken. And one very important, we get some X-rays which are like this, that actually doesn't help us. So we should tell them outstretched hand, left hand, and wrist as well as the entire hand should be there. That is one very important. And it comes with the more I think the student they practice, the more easy it becomes for everybody. So, yes, ma'am.
Yeah. So these are all the important sites to be seen that I already mentioned. Then bone formation, that is, and as Anurag sir has already mentioned, we have to see for the endochondral bone formation, and their epiphyseal center we have to see. And usually at birth, as we have already discussed, hypothyroidism, you have to see the distal femoral epiphysis. Next. So this is already I have discussed, and Anurag sir has also discussed. So you are supposed to see the carpal bones, epiphyseal metaphysis comparison, their fusion, and the long bones. So these are the things we have to see.
This is, yes, we covered this.
Yeah, okay. Okay, so we have already discussed, but Atlas method, we have, as we have discussed, it is usually inter-observer variation is wide. So Tanner White is very good, but it takes at least 20 minutes to do the scoring. Bone Expert is not easily available. So we have to use the fastest available method. That is, we have discussed, we have to see these 4 things, and we can roughly reach to the near bone age. If you want to be exact, then you have to follow any of this method. Now, bone age will be delayed in which conditions that you are supposed to know. So in CDGP, hypothyroidism, growth hormone deficiency, Cushing's disease, and systemic illness, the growth bone age will be delayed. Bone age will be advanced in obesity, and particularly exogenous obesity and precocious puberty. And bone age is not reliable in Turner syndrome and skeletal dysplasia.
To now moving on from the questions part, that is the theoretical aspects of the questions that the PGs need to answer. We move on to the practical questions that the MD students face. And so, ma'am, the most important question after this exhaustive talk on growth is that how should we measure height and the body proportions, ma'am?
Okay. So in children less than 2 years, you have to use the infantometer. And as Dr. Pratik already shown, you have to take the proper with the measurement with the infantometer, and the feet should be touching the infantometer. For children about 2 years, you have to use the stadiometer, and you have to take care that the occiput, the shoulder blade, the hips, and the heel should touch the wall or the stadiometer rod. So that parameter should be taken, and the child should be seeing in the Frankfurt plane. So that particular precautions should be taken. And now it is very important to take the upper segment, lower segment ratio. For taking upper segment, lower segment ratio, we have to make the child sit on a table, First, take the total height of the standing height of the patient and make the child sit on the table. And that then you take the height of this child, that is then you minus the height of the table from that particular height. So that will give you the sitting height of the patient. And so that will be upper segment. And after, if you minus that's from that, then it will be from the total height, then it will be a lower segment. And if it is usually 1.7 at birth, and usually decreases by 0.07, and usually becomes 1 per year, and it usually becomes 1 by 7 to 10 years. Okay. And one thing you have to remember is there is a difference in the length and the height. So length is usually more by 1 centimeter than the height. So when you make a transition after 2 years of age, you have to take this into account. Okay.
Ma'am, coming to the next station, it was a 12-year-old girl with a height of 132 centimeters and a weight of 20 kg. Ma'am, his mother had a height of 150 centimeters and his father has a height of 163 centimeters. So, ma'am, is the child short? And how do we see whether the child is short for his parents?
Okay. So can you put up the next slide?
Yes.
So first we have to calculate the mid-parental height of this child. So how do we calculate the mid-parental height? Mother's height plus father's height divided by 2. And since the child is a girl child, you have to minus 6.5. And then decide about the height age and the weightage. How do you take? So you extend the line till 50th centile and then draw a perpendicular line, and that will come the height age and the weightage will come. So Dr. Sayan, you can put on
the next slide, please. The charts.
Yeah.
Yes, ma'am.
Yeah. So this is the chart of that particular child, and the child's height is on the 3rd centile. But after taking the mid-parental height, you minus 6 and plus 6. So that is the range of the child in which the child can grow, and the child very well fits in that range. So you can tell that this child is not short, is basically having a familial short stature. So this is the importance of taking the mid-parental height and taking out the height age and the weightage. And the height age they have shown is how to take. So you extend the line till the 50th centile from the height measurement and from the weight measurement, and both is 9 years of age.
Thank you, ma'am, for guiding us through the second station. And coming on to the last station, this has already been just extensively covered by you, ma'am. For a 10-year-old girl with short stature, which X-ray should be done to assess the bone age, the precautions we need to take, and which are the bones to focus, ma'am?
Yeah. So as we have discussed earlier, X-ray to be ordered is basically the X-ray of the non-dominant hand, that is the left hand, from the wrist to the distal phalanx. The fingers should be well spread and the proper exposure should be there. And which bones to focus? You have to focus on in the neonates, lower end of the femur. So that is out of the, but 10-year-old girl is there. So we have to focus mainly on whether the distal phalanx, whether the epiphyseal centers are equal to the size of the metaphysis or they are bigger. With that, we have to see. We have to see the lower end of the radius. We have to see about the ulna, whether it is appeared, what is the styloid process has also appeared or not, and the fusion, whether it has started or not. So these are the things we have to see. And again, as Sir has mentioned, pisiform bone. So usually pisiform bone comes around 10 years. So carpal bones also. Okay.
Thank you, ma'am. Thank you so much, ma'am.